Good morning, my lady. May I please call Dr. Finn, who will take the oath?
I swear by Almighty God
that the evidence I shall give
shall be the truth, the whole truth, and nothing but the truth.
Could you give us your full name, please, Doctor?
Nicholas Fulton Finn.
You have contributed to 2 witness statements provided on behalf of Public Health Scotland for the purposes of Module 3 of the inquiry. The first dated the 27th of November 2023 and the second dated the 21st of May of this year. I'm going to be asking you today about matters covered in the first of those statements, the reference for which is INQ 30401271. Just so that everyone understands the reason for that, is it right that although you contributed to the second statement, the detail of the hospital capacity data collected by the Scottish Intensive Care Society Audit Group, which is covered in that statement, is not something you're able to speak to because it falls outside your knowledge and expertise?
I can, if it would help, I can give some brief background and insight, but if it's the detail that may be required, I wouldn't be able to do that.
I understand. Thank you. In terms of this statement we'll be focusing on, that first statement dated the 27th of November 2023, I understand you have a copy of that in front of you and you're familiar with its contents.
Yes, that's right.
I'd like to start, please, with your professional background and relevant roles you held during the pandemic. Could you summarise briefly, please, your qualifications and professional background prior to the pandemic, first of all?
Yes, I qualified as a doctor at Glasgow University back in 1981. I worked in public health as a registrar and a trainee. I then, for a period, was a Director of Public Health in 2 health authorities in England and Wales, and moved into the Health Protection Agency in 2002 as a consultant, first locally with Cheshire and Merseyside, and then in 2007 I moved to Colindale, which is the Centre for Infectious Disease Surveillance with the Health Protection Agency. For a period, for about 3.5 years, I was the interim director of the Centre for Infectious Disease Surveillance, before being appointed as Deputy Director of the National Infection Service within PHE, later UKHSA. I was Incident Director during the 2009 pandemic and was Incident Director, along with Susan Hopkins, in the current pandemic from January 2020 through till December 2020. I then moved to take up a position in Scotland as Director of Public Health Science with Public Health Scotland, and I've been in that role since.
Moving, please, to the creation of Public Health Scotland. Public Health Scotland was launched on the 1st of April 2020, is that right?
That's right.
Could you explain briefly, please, the background to the creation of Public Health Scotland and, broadly speaking, its role and responsibilities?
Public Health Scotland came into being in 2020 following a number of years of consultation about how we could improve the focus for public health within Scotland. As a consequence of various consultations and papers, it was felt that bringing together the health improvement element, which existed in Health Scotland, and one of the national boards, and the divisions within National Services Scotland, which was health protection and data and digital, bringing these 3 things together would create a better focus, if you like, for public health and allow us to look at public health in a much wider context. The mission of Public Health Scotland is to create a Scotland where everybody thrives, and that is our primary goal in the work that we do.
The November 2023 PHS statement addresses the impact of the timing of PHS's launch, in particular at paragraphs 13.1.1 and 13.2. The statement describes responding to the pandemic whilst establishing a new national public health organisation for Scotland as a uniquely and highly challenging scenario. Could you explain, please, what particular challenges this gave rise to?
There were probably two or three. First one, we were having to create new systems because obviously our governance structures had changed, our management structures had changed. So we were creating new managerial systems, we were new finance systems, we had HR issues that needed to be resolved. We needed to look at the structures of this new division because part of the element was about how we bring together the three elements that existed prior to April 2020 and use that to provide something which was more cohesive, which addressed the sort of wider issues. So there was that aspect to it. We also had to deal with the fact that we were having to respond in a fairly major way to the pandemic threat, which meant that something had to give, and as a consequence, the focus was by and large on responding to the pandemic. But these were big challenges, and they've had to subsequently be dealt with in the aftermath of the pandemic.
To your knowledge, and appreciating you joined PHS at a later stage, did these challenges have any impact on the ability of PHS to contribute to the healthcare response to the pandemic? For example, in relation to the provision of relevant data to the Scottish Government?
I think one of the things that the creation of Public Health Scotland did was actually create greater resilience in the system. So as an organisation with a much larger staffing numbers, we're able to draw on staff from different areas to bolster up, to support the effort. So I would say that actually the creation of Public Health Scotland enabled greater resilience and in fact helped the response. One could argue that, you know, over a number of years health protection services have not had the investment that perhaps would have been accorded it, but we were able during 2020 to go out and recruit additional staff to make sure that we were able to deliver what I think we saw were essential services during the pandemic.
PHS brought together three legacy bodies, and you've referred to those in brief already, but just to be clear where they fell, the first of those was NHS Health Scotland, which was a national health board, is that right?
That's correct.
Health Protection Scotland was the second.
That's correct.
And the Information Services Division, the last two both being components in the Public Health and Intelligence Strategic Business Unit, which itself was part of the National Health Board, NHS, National Services Scotland. Have I summarised that correctly?
Yes.
Is it also right that all staff and functions from the legacy bodies transferred across to PHS with two exceptions? One relates to corporate services staff who moved from NHS Health Scotland to NHS NSS, and the other exception being the antimicrobial resistance and healthcare associated infection function and staff, which had been part of the Health Protection Scotland. And that remained with the NHS NSS rather than transferring over to PHS. Is that again a correct summary?
Yes, it is.
In terms of the ARHAI exception, could we have on screen, please, paragraph 1.1.7 of the November statement? And it's on the screen for us now. Starting 4 lines down, please. Prior to the 1st of April 2020, PHS legacy organisation HPS had a role in infection prevention and control when it encompassed ARHAI. This ceased on the 1st of April 2020 when ARHAI remained with NSS. Professional collaboration between PHS and ARHAI continued throughout the pandemic, which is discussed in more detail below. PHS's role in providing advice, guidance and expertise to prevent infection in healthcare settings has been limited since April 2020. We'll come on in due course to look at how PHS collaborated with ARHAI on guidance. But put simply, is it right that IPC guidance for healthcare settings was never one of PHS's responsibilities because of the ARHAI transfer exception?
That's correct. As of 1st of April, that responsibility remained with ARHAI, and the focus was solely on ARHAI for IPC in healthcare settings.
That document can come down now, thank you. In terms of PHS's role in the Scottish COVID-19 response plan and arrangements, the PHS statement at paragraph 1.4.3 describes 4 response programmes and 3 enabling programmes in place in June 2020. One of the response programmes was clinical response and guidance, is that right?
Yes, that's correct.
Although for reasons we've just touched on, this did not include IPC guidance for healthcare settings. And one of the enabling programmes was data and analytics.
Yes, that's right.
Did this role flow from PHS being the main provider of official health and social care statistics for NHS Scotland?
That's correct.
The placing of the NHS in Scotland on an emergency footing is dealt with at paragraph 2.2.1 of the November statement. And it is explained that this lasted from the 17th of March 2020 to the 30th of April 2022. Is that right?
Yes, that's right.
This impacted on PHS's operational autonomy?
Yes.
In particular, in relation to public health advice, is it right that the lead role for the offer of public health advice transferred from Health Protection Scotland, later Public Health Scotland, to Scottish ministers?
Yes, that's right.
And this meant, for example, that while PHS continued to offer the Scottish Government advice on the wording of relevant guidance documents, the Scottish Government was under no obligation to accept that wording. Were there ever times when the Scottish Government declined to follow PHS advice on matters relevant to the healthcare response to COVID-19?
The healthcare response would, by and large, fall outside our remit. The healthcare provision in Scotland is devolved to boards, of which there are 14, and those boards take responsibility for the delivery of healthcare in Scotland. And it's slightly different to England, where there is NHS England, which has oversight, by and large, of many of the activities of the health service in England. Therefore, what we would be doing is working very closely with the boards to make sure that any guidance that was issued incorporated their views, but ultimately that advice would come from Scottish Government.
PHS sat on the Scottish Government For Harms Advisory Group, is that right?
Yes.
Although you personally did not join that group until April 2020?
Correct.
Was that
April? It would be April. I think it was later than that. April 2020. I moved to.
I'm
Scotland.
sorry. If I said April 2020, I meant April 2022.
Yes. Sorry. Yes.
Forgive me if that was my error. Was that one of the forums for PHS to provide strategic advice on managing both the direct and indirect harms to health caused by the pandemic?
It was one of the forums. Yes.
In what other ways and through what other forums was this advice provided?
We were party to the committee that was formed around giving COVID advice, which was led by, I'm sorry, I can't recall his name, but was led by a senior academic, and this tried to coordinate advice from both academics, clinical colleagues, and Public Health Scotland, and that was in addition to the For Harms.
PHS also sat on the COVID-19 Nosocomial Review Group, is that right?
Yes.
Did you yourself ever sit on that group?
No, I didn't.
At paragraph 3.3.17 of the November statement, it is said that PHS supported consideration of transmission risk in hospitals through expertise and evidence from a public health and health protection perspective. Was ARHAI also represented on that group?
I believe so.
To what extent, in principle, understanding that you yourself were not involved, would PHS have questioned the views of ARHAI on COVID transmission in a hospital setting?
I wasn't around, as you mentioned, and I'm afraid I'd be unable to comment on exactly the advice that was given at that point.
Moving, please, to the extent to which PHS was responsible for COVID-19 relevant guidance for healthcare settings. Could we have on screen, please, paragraph 3.4.15 of the statement? And the statement here says this: when PHS was formed on the 1st of April 2020 and ARHAI remained within NSS, guidance documents that had been previously published that included content related to IPC became jointly owned and maintained by PHS and ARHAI. ARHAI was responsible for the IPC content and for providing healthcare IPC support to local HPTs. PHS was responsible for the wider health protection content within the guidance and outbreak management support for HPTs. While this statement focuses on healthcare settings where ARHAI led on IPC advice and guidance, it should be noted that PHS led on IPC measures in non-healthcare settings. The statement goes on in the next paragraph to identify 3 categories of guidance after the 1st of April 2020. Health protection guidance developed and maintained by PHS, health and social care IPC guidance developed and maintained by ARHAI, and joint outbreak management and IPC guidance developed and maintained in collaboration between PHS and ARHAI. Just taking an example of health protection guidance which was issued by Public Health Scotland for secondary care settings, could we have on screen, please, INQ 30189278? And looking at the first page, we can see there this is a December 2020 document, COVID-19 guidance for secondary care settings. Did you personally have any involvement in advising on the content of this or other similar guidance for healthcare settings?
No, I didn't. That predated my role in Public Health Scotland.
Going to the top of page 5, please. This is an explanation of the scope of the guidance and the target audience. And it says this guidance is to support those working in secondary care settings, e.g. hospitals, with general public health measures required to manage the spread of COVID-19. This guidance covers key issues for secondary care from a health protection perspective. This should be read together with the IPC addendum on secondary care. The contents table is on page 4. And we see a fairly wide range of topics covered, including key public health measures to prevent the spread of COVID-19, testing for COVID-19, and then we see there's a section on infection prevention and control in secondary care settings, section 7. Could we go to that section, please? It's page 17. And paragraph 7.1 says, under infection prevention and control and PPE, staff in secondary care settings should refer to the COVID-19 IPC addendum within the National Infection Prevention and Control Manual for all IPC guidance relating to care and provision in the secondary care setting. Was this generally how the division of responsibility between PHS and ARHAI was dealt with in PHS guidance for healthcare settings? That is by way of a cross-reference in the health protection guidance to the ARHAI-produced IPC guidance for healthcare settings.
That's correct. The decision was taken fairly early on by Scottish Government that Public Health Scotland should continue to use the Health Protection Scotland brand in its documentation. And that meant that, and that was because it was a trusted name, people were familiar with it, they knew where to go, they knew how to access it. Therefore, I think it's quite nicely described in the previous slide that you put up, where you described the three areas that ARHAI took responsibility, we took responsibility, and then where there was joint responsibility. So, yes, they were published on the Public Health Scotland website under the Health Protection Scotland name, but they were jointly developed with ARHAI taking responsibility for the IPC aspects in healthcare. I think it's important to realise that ARHAI's remit is defined because it's part of NHS Assure, which is for healthcare associated infection. That does leave a gap when it comes to community settings, which is why in that document we describe the role of Health Protection Scotland in taking the principles that were developed for the healthcare setting and adapting and trying to use them in those wider settings. This is something that's being discussed at the moment to make sure that this gap is addressed, and we're in active discussion with ARHAI and indeed with Scottish Government about how we address this going forward. But during that pandemic, it was addressed because of the close working relationships that had been developed over many years with staff in ARHAI, and those continued throughout the COVID pandemic.
Dr. Finn, forgive me interrupting. The structure seems unnecessarily confusing to somebody on the outside.
It was not our sort of primary way of putting it across, but we had to reflect the fact that there was a shift in responsibilities, and we were directed to use the Health Protection Scotland logo and name in any guidance that we used.
Did this approach to COVID-19 guidance for healthcare settings, which follows from the structural separation of ARHAI from PHS on its creation, create a risk that there would be gaps, overlap or duplication in the guidance being issued to healthcare settings?
One of the things that we worked, well, I understand people worked very actively on, was making sure and ensuring there was no duplication, there were no gaps. And again, I refer back to the relations that had been built up over many years when ARHAI was part of Health Protection Scotland. Those relations continued through into the 2020 and beyond. And as my colleague, Dr. McMenamin, said in the last COVID inquiry, it was one of the most amicable divorces that he'd ever heard of. So those working relationships ensured that any duplication or gaps were not missed.
That document can come down now, thank you. Particularly during the transition period, are you aware of there having been any confusion over who was doing what in relation to IPC guidance for healthcare settings?
No, I wasn't aware.
Did the separation of ARHAI from PHS have any impact on the ability of PHS to fulfil its guidance responsibilities?
Clearly, about a third of the health protection staff were involved in ARHAI, which covered not just healthcare-acquired infection, but antimicrobial resistance and aspects of animal disease. If you lose a third of your staff, that will have an impact potentially on your ability to respond. However, I go back to the point that there were strong relationships established, and we put aside any sort of managerial structures to ensure that we worked very closely together and overcame any sort of issues that may have arisen.
Turning please to PHS's role in relation to the collection and provision of COVID-19 data to relevant healthcare settings. Could we have on screen, please, page 44 of the November statement, paragraph 4.5.1. And the last bullet point here, and the context is the structures and processes that were most critical for the provision of this data. And this is provision of data about healthcare settings to the Scottish Government and other partners. PHS hosted a daily morning huddle with participation from PHS, Scottish Government and other partners to review daily trends in case numbers, hospital impact, intensive care unit cases, and deaths to capture occasional data quality issues before officially sharing with Scottish Government more widely to inform the Scottish Government's daily press conferences. For this daily meeting, the RTE team would produce an overview of the data and identify any concerns in trends or issues of note. NHS hospital admissions data is dealt with over the page towards the bottom, paragraph 4.5.4. And it says timely NHS hospital admissions data was also vital. This was obtained through the rapid reporting system and intensive care unit data provided through the Scottish Intensive Care Society Audit Group, and in particular in the early phase of the pandemic, directly from Health Board service returns to the Scottish Government. National Records of Scotland, death data linked to COVID-19 testing data was also crucial. And then you provide a little more detail about the daily reports which were made available to the Scottish Government at paragraph 4.5.10, that's page 47. SIGSAG rapidly repurposed its reporting systems, which usually operate on a monthly basis, to develop a daily flow of data from all intensive care units in Scotland. This allowed daily reports to be issued by 9 a.m, reporting the number of patients in ICUs across Scotland. This was then linked with data from testing laboratories to identify ICU patients with a positive PCR test for SARS-CoV-2, allowing a more detailed daily report to be issued by 12 noon, providing national information on the numbers of patients in Scottish ICUs, their COVID-19 test status, the number of people requiring mechanical ventilation and other life support therapies. We have an example of a daily report on acute bed occupancy, levels of care and COVID status of patients made available to the Scottish Government, which was exhibited to the second PHS statement of May this year. Appreciating that you may be not able to speak to the detail of the data in it, I'd just like to check with you whether this was the type of daily report being produced. Could we have it on screen, please? It's INQ 3072596. And this spreadsheet provides figures for each hospital grouped by health board and then network, as we can see on the left-hand side. It's from December 2020. Did you personally have any involvement in the collation or presentation of this type of data for these types of reports?
No, I didn't.
For the day it is dated and the previous day, it provides numbers of empty, full and closed beds, the number of patients at each level of care, so level 0, level 1, level 2 and level 3, and the number of suspected and positive COVID cases. The inquiry understands that a closed bed is one which is closed due to a lack of staff or equipment to staff the bed. Is that also your understanding?
Yes, that's correct.
Is this the daily report which would have been discussed at the daily huddle with the Scottish Government?
Yes, it was.
Did you personally ever attend those huddles?
No, I didn't. This had become a fairly routine practice by the time I joined Public Health Scotland.
What this spreadsheet does not do is give any information about whether prescribed ICU-trained staffing ratios were being maintained. Would you agree?
That's correct, yes.
It also does not give information about, for example, how many patients were receiving mechanical ventilation or other respiratory support, does it?
No, it doesn't.
Or whether the empty beds were level 0, 1, 2 or 3 beds.
That's correct.
It also doesn't give any figures for bed occupancy as a percentage of baseline or surge capacity. Would you agree?
Yes.
Do you think it would have been helpful if these daily reports had contained such further data?
I think it's worth me just explaining a little bit. This report that you see was the one that was submitted and sent in to Scottish Government at fairly high level, We tried to keep it as simple as possible. And this had been evolved since April through to May in discussion with Scottish Government, where they were clear about the information they wished to have. There was a separate report produced each day, which was circulated to the intensive care consultants, to the coordinator for intensive care across Scotland, and that provided the detail that you've just described. It talked about the staffing ratios, it talked about the types of ventilated beds, etc. So that detail was available. It was a second report that was not circulated to Scottish Government. It was very operational, and it was felt that it could be potentially confusing. And it was really about how the clinicians and the operational management of the units were working. I think it was important that Scottish Government, at their request, were clear about how many beds were full, how many were closed because of staffing potential issues, and those that were empty, and that would allow them to understand where the pressures were in the system.
Stepping back and looking at this document, and you've indicated it was intended to be fairly high level for Scottish Government, but it's not easy at a glance, is it, to understand how well hospitals were coping with demand? Would you agree?
Yes, although if you look at the column of closed, that's giving you an indication of beds that could be available but were unavailable because of staffing. So, for instance, a level 3 bed requires one-to-one nursing care. A level 2 will require 2 members of staff, and that second member of staff could be staff more generally from the hospital. And then what it's saying in the fact that there are closed beds, that there are staffing issues within that hospital and trying to maintain the capacity it could provide should the staffing have been available.
But again, there's no breakdown there as there is of the closed beds as to what level of care they relate to.
No, there's no level. That isn't available in this report. It would have been available in the second report that was produced. And I'm very happy to produce a copy, an example of that, if that would be helpful to the inquiry.
That would be helpful. Thank you. In terms of how an at-a-glance one-page spreadsheet like this could be improved to give a view of how well hospitals are coping with demand for government. So not those involved in the management of the hospitals, but government. How would you propose this document is improved?
Well, as I said initially, the work started in April, and throughout April and May, there is an enormous amount of data collected through the system. And throughout April and May, there was a lot of toing and froing and discussion about being clear about what data Scottish Government needed in order to understand and to help them develop their policy and their understanding of what was happening. So the data you have is the data that they requested that they would need in order to make those decisions. Behind the scenes, there were professional advisors in Scottish Government through the Chief Medical Officer's office, who would have probably been able to look at this and make a sort of more of a clinical judgment, and would then influence any or answer any questions that may have been addressed by either senior civil servants or ministers.
That document can come down now, thank you. Turning please to testing and surveillance. You have dealt quite comprehensively with your colleagues with the early work which was done on testing and capacity and capability in the November statement. And I'd urge anyone interested to look at paragraphs 5.1.27 to 5.1.31 and 5.2.3 to 5.2.4 in particular. In the interest of time, I'd like to focus, please, on whole genome sequencing and its role in identifying or ruling out nosocomial infections. Is it right that PHS contributed to the development of a UK service offering rapid sequencing of COVID-19 samples so that genotypes of the virus, that is the genetic fingerprint, could be compared to other samples?
Yes, I think I just need to explain that in a little bit more detail. At the beginning of the pandemic, the capacity within Scotland to undertake whole genome sequencing was very rudimentary, if almost non-existent. What was created in the early months of the pandemic was COG UK, which was a collaboration of academic and other organisations, which provided a service to Wales, Northern Ireland, Scotland and England in terms of increasing the capacity to undertake whole genome sequencing. Throughout 2020, my colleagues worked with Scottish Government to get the funding and the resource needed to introduce whole genome sequencing as a sustainable service into Scotland, and then to expand that. And our reliance on COG UK diminished over time as our own service developed in Scotland.
I see. So the service that was launched on the 2nd of December 2020, was that the UK-wide service?
No, that was the Scottish service.
Can you explain, please, how that service helped infection prevention and control and public health teams to investigate community and hospital-based outbreaks?
There's been a lot of discussion about whether or not, let's say, an infection identified in the community was either taken into the hospital, or whether the hospital contributed to development in the community, or whether indeed, I think as I previously said in the last inquiry, hospital patients had actually seeded outbreaks in care homes. What the whole genome sequence does is provide a sort of genetic fingerprint to say that if you've got two samples with the same sequence, they are somehow related or linked. What it doesn't do is tell you the direction in which that relatedness exists. So it can't say this has come from the hospital and gone into the community, or vice versa. For that, you need the detailed epidemiology to understand when an individual was infected and could it have been acquired in the community and brought into the hospital. So it's a good example of why epidemiology and microbiology need to work extremely closely together, and that service needed to be developed.
So is it right that whole genome sequencing was most helpful in ruling out nosocomial infection rather than ruling it in, so to speak?
Yes. That would be one use. But as I say, it simply determined the degree of relatedness between samples. You needed to understand the sequence of events in order to draw a potential conclusion about which direction that infection had happened.
But if you had, for example, 15 people in a ward and their samples were different, looking at that genetic fingerprint, that would assist, wouldn't it, in terms of whether it was a nosocomial infection outbreak or not?
Absolutely. You'd be talking about 15 separate introductions.
How did whole genome sequencing improve nosocomial infection prevention practices? The statement indicates that it did.
Well, I think it would be along the lines that you've suggested. It would be useful in looking at outbreaks to determine, whether or not this could feasibly have been nosocomial transmission, or it could have been, let's say, 15 different introductions. After understanding that, it would allow the team to look at infection control practice, and if it had been one single strain affecting all of the 15 people, they'd then be able to look at the practice and see whether there had been any breakdown in what had been done, and it would enable them to then look at how they could strengthen or improve infection control in that particular setting. So it was useful in identifying gaps and weaknesses and providing also reassurance where that wasn't an issue about the adequacy of infection prevention controls.
Moving, please, to data on nosocomial infections. PHS worked closely with ARHAI on a report called Changes to the Severity of COVID-19 and Impact on Hospitals in Scotland, which provided some statistics on nosocomial infections. Is that right?
I don't recall that report, but if it's
If it assists you, it's paragraph 5.5.14 in the statement in front of you. We don't need to display it, but
Okay.
that might assist you if you want to refer to it. Paragraph 5.5.15 of the statement, and in fact, let's have that on screen, please, page 70. This, for completeness, if we can go up to the paragraph above that just explains the report. So this section explains 5.5.13 at the top, please. That PHS does not hold data on hospital-acquired infections. ARHAI is responsible for routine monitoring and reporting, but the paragraph below, PHS worked closely with ARHAI on the report I've just referred to. And then 5.5.15 gives a summary, some headline figures from the report. The report found that between December 2021 and mid-May 2022, there were, I think it should say, 14,215 hospital admissions, all admission types. And of these, 5,644 were probable or definite hospital onset. Just to be clear what definition of nosocomial infection was used for that report, which is explained in the paragraph above, these were defined as having probable or definite hospital onset, with probable onset defined as the test taken 8 to 14 days after admission, and definite onset being defined as the test being taken 15 days or more after admission. Is that right, looking at the statement?
That's right.
And so looking at that figure, the 14,215 figure, can you help with whether that is the total number of hospital admissions for a person with a positive COVID-19 test? It would seem to follow from the explanation given in those paragraphs.
I'm not familiar with the report, and I'm afraid I wouldn't be able to comment on that. I'm sorry.
Okay. If that were correct, that is the total number of hospital admissions for a person with positive COVID-19, with a positive COVID-19 test, that would mean a figure for Her Ladyship to take from this of nearly 40% of that 14,215, by my calculation, being probable or definite hospital onset cases.
Yes, I'd agree with that.
That can come down now, thank you. Paragraph 5.6.14 of the November statement explains that PHS does not hold or have access to data around the proportion of patient deaths within healthcare settings in Scotland, which are attributable to patients having died with hospital-acquired COVID-19 infection. Is that right?
Yes.
Can you explain, please, why that is?
The information on hospital-acquired infections is basically stored in a system called ICNet, or of which I think about 11 or 12 of the boards have adopted. There are 3 or 4 boards which use their own system. ICNet is not accessible by PHS because obviously it contains patient detailed information. We would therefore be reliant on working with ARHAI, which is where the close collaboration would come in, to make those sort of links and to use that data. We can only make inferences, and one of the, at the beginning, until we changed our definition of how we would identify a COVID-related death, we were using a definition of someone who was COVID positive and died within a certain period of that diagnosis being made. That tended to overemphasize, if you like, because many of the people who actually developed COVID had many comorbidities, and it may have been another cause that was eventually led to their particular death. So that was refined over time, and we adopted the National Record Scotland, NRS, data, which was that we would only use deaths ascribed to COVID if they were included in the death certificate. There are challenges then in trying to link that back to the hospital data given that we're talking about 3 different data sets. There is work underway to look at how we can make that data more accessible and in one place, and that is work in progress that is being undertaken at the moment.
So is it the case that it's simply not possible to say at the moment the proportion of patient deaths within healthcare settings in Scotland which are attributable to patients having died with nosocomial infections? Or is it the case that that is information held by another organisation within Scotland?
I think it's not possible at the current time.
I'd like to come, please, to the risk for healthcare workers and their households. Could we have on screen, please, page 85 of the November statement? Paragraph 6.7.4, please. PHS was included in the REACT Scot consortium looking at the risk of COVID-19 hospitalisation among healthcare workers 18 to 65 years old, their households and other members of the general population. Work prior to this was insufficiently robust or comparable, and there were a lack of studies evaluating the risk of COVID-19 infection in household members of healthcare workers. And the next paragraph, please. The findings published on the 28th of October 2020 in the BMJ showed that during the first peak of the pandemic, whilst the absolute risk remained low, patient-facing healthcare workers were at 3-fold higher risk of hospitalisation with COVID-19 than the general population, and individuals living in the same households as a patient-facing healthcare worker were at 2-fold higher risk than the general population. The study found that healthcare workers and individuals living in their households accounted for 1 in 6 of all individuals hospitalised with COVID in Scotland. The study highlighted that whilst the risk for many healthcare staff is similar to that of the general population, there is higher risk to some staff. The results help to inform action to protect those healthcare workers at greatest risk. Can you help, please, with how the results helped inform action to protect those healthcare workers at greatest risk?
I'm afraid this publication and the results and the implementation happened prior to my appointment in Public Health Scotland. But what I do know is that using information that was coming out of studies like this, we were able to stratify potential risk factors that might put people at greater risk, and that I would have expected that then to have been part of an occupational health assessment for people who were either dealing perhaps with a cohorted ward where COVID-19 patients were being managed, or in frontline staff. So there would have been an occupational health assessment to determine those at greatest risk and advise them appropriately.
That document can come down now, thank you. The next topic I'd like to ask you about, please, is work done by PHS on health and healthcare inequalities. Pre-pandemic health inequalities are dealt with at paragraphs 8.2.1 to 8.2.2 of the statement, if that assists you. The position is put fairly starkly. Scotland went into the pandemic with the worst health inequalities in Western and Central Europe and the lowest life expectancy in Western Europe. Just to be clear on terminology, there's an important difference, isn't there, between health inequalities and healthcare inequalities. Can you just explain that difference, please?
Well, health inequalities would be those inequalities that people experience through either their environment, their income, the habits, what they do, etc. So it's a very generic term influenced by many factors. Healthcare inequality would be people where there were situations where people were unable to access or where there were challenges in the provision of health care in an equitable way. So one is about a general responsibility. The second one is about potentially systems and how we go about providing access and engaging with patients.
And this section of the statement is dealing here with health inequalities, isn't it?
Yes, it is.
It is clear from the reference in the paragraphs which follow from the reference to work done in 2013 and 2019 on the causes and solutions to health inequalities, that there was an awareness of the state of health inequalities in Scotland pre-pandemic. Is that right?
Yes.
Was there also an awareness pre-pandemic that a pandemic would be likely to exacerbate existing health inequalities?
There should have been. I mean, if we look at the history of pandemics and we go back to 1892 to the Russian pandemic, and again in 1918 to the Spanish flu pandemic, the groups that were most affected were those in, conditions of overcrowding, typically the situations we describe as deprivation. A feature of the 1892 pandemic was that it was felt that a major factor in the rapid transmission of the pandemic was the fact that people needed to work. If they didn't work, they didn't get paid. Therefore, they were turning up to work with symptoms. They were affecting their colleagues. So it's been well recognised that health inequalities will be exacerbated during a pandemic, and we need to be thinking about what measures should be put in place to try and minimise those, or, as we would be trying to do in Public Health Scotland, to try and take every effort to ensure that those inequalities are minimised generally in everything we do.
Was any planning done pre-pandemic to ensure that mechanisms for mitigating such an exacerbation could quickly be put in place in the event of a pandemic?
The pandemic plan that was developed for the UK was in 2011, and that described very much the response that should be taken to manage the pandemic. I can't recall whether there were any specific measures about what we might do regarding the work situation or how we might help those in deprived communities. But certainly some of the measures that were introduced during the pandemic were designed to try and mitigate that, and that was furlough, where people who were unable to work, either through COVID or for whatever reason, were provided with an income to ensure at least they had some resource or finance.
Looking at the impact of COVID-19 on health inequalities, PHS undertook analysis of the inequalities relating to the direct and indirect health harms. And the statement indicates that this was led by colleagues from NHS Health Scotland who had been involved in pre-pandemic health inequalities work. Is that right?
That's right, yes.
When did that work start? And appreciating you may not have been there at the time.
This was in relation to the pandemic itself in 2020. I think it started fairly quickly because the colleagues in question, this had been something they'd been working on for many years in respect to health inequalities, and therefore they were well placed to rapidly identify and adapt the work they were doing to look into this further. But I can't recall exactly when it happened. As you say, I wasn't there at that particular time.
Could we have on screen, please, paragraph 8.4.4 of the November statement? The findings of a PHS paper are summarised here. And from that paper, it was clear that people living in more deprived circumstances were more likely to be exposed, infected, become unwell, and to die from COVID-19 because of socio-economic inequalities, and that the measures put in place to control the pandemic are also likely to have had disproportionate impacts on the most deprived groups. There's no date given for that paper here. Can you help at all with the date of that paper?
I have a feeling that paper was in April 2020, but again, I can look into that and provide a copy of the paper to the inquiry. I mean, just commenting on it, as I've said, the impact that pandemics have had in people in socioeconomic and deprived situations is well recognised. One only needed to look at the mortality data coming out of both of those pandemics that I mentioned to see that. So this is well recognised, and perhaps what it highlights is that maybe the emphasis was on looking at the response and not thinking about what we might do more generally in society.
Well, let's look on at a little more detail. Going over the page, please. There is a diagram, which we don't need to go to the detail of now there, indicating direct health impacts and indirect health impacts. And then at paragraph 8.4.7, data relating to occupation is addressed. And it says the briefing referred to above. And looking back up, that appears to be a reference to the briefing for forgive me, we don't need to go to it on the screen. But at paragraph 8.3.5 of the statement, there is a reference to a briefing for Scottish Government ministers taking place in June 2020. Can you help with whether that is the briefing referred to above?
I can't at this point in time, but again, I can clarify with you and provide that information after today.
So the briefing, for which may be the briefing for Scottish ministers in June 2020, found that using occupation as an individual marker of socio-economic position and data between March and December 2020, the COVID-19 death rates for working age adults employed as process plant and machine operators was 11 times higher than those working in professional occupations, while all-cause deaths was 5.3 times higher. The next paragraph addresses other groups for whom direct COVID-19 mortality is higher. So direct COVID-19 mortality is also substantially higher for those in some ethnic minorities in Scotland, with increasing age amongst men compared to women, and for those with pre-existing health conditions. Early analysis of data on mortality from COVID-19 for people with learning difficulties suggests that this might be 3 times higher than in the general population. And then at 8.4.9, there is this. In addition, the COVID-19 mortality rates have been found to be higher in some local authority areas than others. Data from the first wave of the pandemic show that this can be explained by higher income deprivation levels and household overcrowding. In terms of inequalities in indirect health harms, over the page, please, 8.4.13. This is an assessment from May 2020, as we can see from the paragraph above, and it indicates here that the assessment looked at a range of mechanisms through which physical distancing measures could have impact on health, including economic impacts, social isolation, health-related behaviours, and disruption to essential services. And potential impacts identified in relation to disruption to health and social care services include the potential for the cancellation of face-to-face appointments to lead to inappropriate care or barriers to care for people who require interpreting services, including deaf people who use British Sign Language, and then the potential for delays to non-urgent healthcare provision to detrimentally impact on people with long-term health conditions. It was suggested that delays to treatment could result in ongoing unresolved morbidity and delays to prevention activities such as cancer screening, which could result in longer-term adverse health impacts. So it appears that the analysis done by PHS by May-June time in 2020 led to a tolerably clear picture of particular groups being disproportionately affected, both in terms of direct and indirect health harms caused by COVID-19. Is that fair?
Yes, that is fair.
And that picture was shared with the Scottish Government at the time, was it?
Yes.
There was, in fact, a meeting of the Scottish Government COVID-19 Advisory Group, which took place on the 9th of April 2020, and that's addressed at paragraph 8.7.1 of the November statement. Could we go to that, please? It's page 114. This paragraph explains that at this meeting, a paper entitled Calibrating the Impacts of COVID-19 with the Impacts of its Control Measures, Informing Decision-Making on NPIs. It was a paper which was authored by Dr. Jerry McCartney, who was an inequalities expert, and a consultant in public health at PHS, was considered at that 9th of April 2020 meeting. And looking towards the bottom of the page, the last bullet point on the page highlights a particular aspect of the paper. There are difficult decisions to be made on when and how to reduce MPIs. These will need to balance the potential impacts of COVID-19 mortality and morbidity, pressures on health and social care services, and the unintended consequences across society, including on population health and health inequalities. Further work can and should be done to estimate the intended impacts of NPIs on COVID-19 and the unintended impacts on health and other outcomes, urgently to inform this decision-making. There is a risk that on many measures the impact of the NPIs for COVID-19 could be more deleterious than the impact of the less mitigated approach to COVID-19. This balance requires careful, ongoing monitoring and consideration. Appreciating you had not joined PHS by this point, I'd just like to ask you about the response of the Scottish Government to this paper and your understanding, if you can help, of action taken in response. And at paragraph 8.7.2, just scrolling down, thank you. The minutes of the meeting noted that government is considering points raised in the paper and expressed that the paper should feed into broader thinking, and that while long-term issues are clearly incredibly important, there are urgent issues also to address. In the last week of full reporting, there were almost 800 care home outbreaks in England. It is important that we address the issues of today as well as tomorrow. What is your understanding of what, if any, action was taken by the Scottish Government in response to the suggestion in the paper, in particular, that further work could and should be done to estimate the unintended impacts on health and other outcomes, urgently to inform decision-making?
I'm afraid I can't comment on that, but again, I could seek to clarify that and would provide a written response to the inquiry if that would be helpful.
We'll come on to specific action taken on ethnic health inequalities in due course, but in terms of the general position, you can't take that any further for us today.
I think what you've described is a real dilemma between, on the one hand, do we try to take measures which will impact on the speed or the size of the pandemic, and trying to weigh that up against the potential disbenefits or impact it could have on certain groups. And I think it would be fair to say that the pandemic planning that had been done prior to 2020, things like lockdown, some of the measures that had been taken had not been part of that initial planning assumptions, albeit it was on the basis of a flu pandemic, which to some extent one would be very similar. So there is a sense that some of these measures that were introduced, the work had not been done beforehand to try and estimate what the impact could be and whether any other measures may have been as effective or could have worked in this situation.
This statement deals with a study on which PHS collaborated, looking at ethnic inequalities in positive SARS-CoV-2 tests, infection prognosis, COVID-19 hospitalisations and deaths, covering a period of March 2020 to April 2022. Can we look, please, to the summary of the findings, which is paragraph 8.8.3, page 116. There is a risk, therefore, that most ethnic minority groups were at increased risk of adverse COVID-19 outcomes in Scotland, especially white, Gypsy, Traveller and Pakistani groups. Ethnic inequalities persisted following community infection, but not following hospitalisation, suggesting differences in hospital treatment. Healthcare inequalities did not substantially contribute to ethnic inequalities. I think that might be ethnic health inequalities. To what does PHS attribute the ethnic inequalities in health outcomes, given that the conclusion of this study is that healthcare inequalities did not substantially contribute?
I think this is a very complex area, and certainly I can recall in England when the first data started to emerge that there seemed to be an adverse impact on ethnic groups from COVID, which would be March, April 2020 time. I think also what's interesting is that as we went through the pandemic, the impact on ethnic groups diminished, such that when we got to the Omicron wave, which was, I think, in 2021, or yes, 2021, the inequalities through COVID had reversed, and the white British population were sustaining the biggest impact, which suggests that there may be a factor in the virus itself or some genetic predisposition that could lead to that. There are also differences in habits. Smoking, drinking, alcohol tends to be lower in certain ethnic groups, which might counterbalance some of the deprivation indices that one would normally expect to see. And we know that certain groups have a certain predisposition to certain conditions such as cardiovascular disease, diabetes, which were factors that contributed to serious illness and mortality. So I think it's a very complex picture. We do know that when we looked at offering vaccination, there were differences in uptake in ethnic groups, and vaccination was a key measure which was introduced to protect the population, and therefore if ethnic groups aren't, we're not able to get that group vaccinated, then one would expect to see an adverse outcome there as well. So I think it's multifactorial, and I think to try and pin it down on one specific issue would not be feasible or credible, in my view.
That document can come down now, thank you. Paragraph 8.8.5 of the November statement deals with the establishment by the First Minister of an expert group to consider the impact of COVID-19 on ethnic minorities in June 2020. Can you explain, please, what work that group did and what recommendations it made, particularly in relation to ethnicity data?
Yes, the group was comprised of a number of key members, both from Public Health Scotland and also representatives of various ethnic groups within Scotland. There were essentially two subgroups. One group was looking at data, the other group was looking at systems and what could be done to try and assess any adverse impact that healthcare systems may have. The particular group looking at data raised the issue that the collection of ethnicity has been for many years and was at that particular point a challenge, both in terms of completeness and the quality of the data. Therefore, being able to accurately describe the impact that COVID and other factors would have on ethnic groups was challenging. I think there were 16 recommendations that came out of that particular group, and currently my colleague Scott Heald is co-chairing a group which is looking at how we implement changes that will improve the quality of that data. In the meantime, Public Health Scotland is using data linkage using something called SMR01, which is the routinely collected healthcare data, which is reasonably complete as a consequence of action taken by the health service, and also vaccination data, because we moved over to a new system in Scotland whereby all vaccination data was collected on a new tool. And this provided an opportunity, given that most of the population in Scotland have been vaccinated, in the region of 90%, we used this as an opportunity to make sure that ethnicity was gathered and collected. So we're using that data as an interim measure and linking that back to healthcare data. And that is the plan will be that is introduced to the various groups. People on the data plan were concerned that there needs to be some explanation, because although a field is completed, people have the option to opt not to say what their ethnicity is. So therefore, there was a concern that that field may bias any interpretations in any one particular group. So that work is ongoing, and there are long-term plans in a group led by Scottish Government looking at how we use something called ARHAI, which is the Community Healthcare Index, which is a unique system in Scotland. It's a 10-digit code which every person using the healthcare system has, and that if we can modify that and include ethnicity data with that, then that should provide a fairly comprehensive way of looking at ethnicity going forward, which would allow us to look at things like access to healthcare, use of healthcare, etc., in a much wider and holistic way.
The group you've just referred to, is that the same as the Racialised Inequalities in Health and Social Care in Scotland steering group?
Yes,
or is
I
that
believe
different?
So. I believe so.
It's the same. Can you help, please, with anything additional from the work of that group or recommendations which you think is relevant for her ladyship to know about, in addition to that work on data?
I think the other group, which was looking more at the systems and what could be done to improve access, or at least to understand what the access issues might be, I think there were something like 11 or 14 recommendations, which ranged from improving education, providing people with appropriate training, dealing with unconscious bias, looking at how information may be conveyed, recognising both the cultural and language issues that may be at play. So again, that group and the recommendations, I believe that work is being taken forward, but the data is primarily the concern of Public Health Scotland.
How are any changes to the data being monitored for their effectiveness?
Well, we don't have the systems in place yet, so it would be, we will have to wait until that is introduced. And one of the ways that we have been looking at the completeness of the data is comparing that to census data, which is reasonably complete. Well, it's the most complete and most accurate picture of ethnic information we have. And so looking at completeness and coverage with that should give some assurance around the completeness of the data.
My lady, I've reached the end of a topic. Would it be a convenient moment for the morning break?
I shall return at 11:30.
All rise.
Price.
Dr. Finn, I'd like to turn, please, to shielding, and in particular, evaluation of the shielding programme. PHS was commissioned by the Scottish Government in 2020 to develop an evaluation framework for the shielding programme. Is that right?
That's correct.
Could we have on screen, please, paragraph 9.3.1 of the November statement? The aims of the evaluation are set out here, and they were to evaluate the effectiveness of the shielding programme, inform the advice, information and support offered to individuals in the shielding group during the pandemic, inform the advice, information and support offered to people at risk more widely during the pandemic, identify lessons learnt for future pandemic planning, and identify lessons learnt for work with at-risk groups. Outreach mechanisms are dealt with in the next two paragraphs. And these included establishing a lived experience panel to advise on the design and implementation of the evaluation. The panel had 10 members, including a black or ethnic minority individual, with people with mobility and sensory impairments, 3 older people, and the carer of a disabled person. The panel also had a practitioner representation, a social worker supporting 3 shielding clients, including somebody with a history of criminal justice involvement and substance use, and an older person in sheltered housing. And it was said that this enabled the evaluation to capture the voice of individuals who would have struggled to engage directly with PHS including those from disadvantaged socio-economic backgrounds. Is it right that 8 members of the panel attended a meeting online in July 2020 to help identify those evaluation questions that mattered most to individuals who were shielding or caring for someone who was?
That's my understanding.
There were 3 parts to the evaluation: an online survey that ran between the 1st and 14th of June 2020, with findings published in September 2020, a rapid evaluation undertaken between March and November 2020 using mixed methods, including focus groups, and an online survey which ran between the 25th of October 2021 and the 7th of November 2021. In terms of the key findings of the evaluation, and focusing please on healthcare, dealing with the first stage and findings from the 2020 work, paragraph 9.3.11, please. The findings were these. The evaluation considered the issue of access to healthcare and related unmet support needs. Healthcare appointments being postponed, cancelled or not available featured more prominently as a concern than individuals being dissuaded from accessing healthcare because of the advice to shield. A July 2020 Scottish Government survey of individuals on the shielding list, included in the January 2021 PHS evaluation report, suggested that almost 1 in 5 respondents had had a healthcare appointment postponed or cancelled. 2% had decided against attending an appointment because of safety concerns. The PHS evaluation findings about the difficulties individuals experienced in accessing healthcare were highlighted to the Scottish Government across the different PHS evaluation reports. Can you help, please, with what action was taken by the Scottish Government in response to these healthcare access difficulties highlighted at all stages through this evaluation?
My understanding is that this information was made available to health boards, and it would be for individual health boards to look at the way they operated their services and how they could address some of the concerns that were being raised. I'm not aware of what action the Scottish Government actually took. I simply understand that given the devolved responsibility of healthcare within Scotland to boards, that the operationalising that would be individual boards' responsibilities.
Looking, please, to paragraph 9.3.16. This deals with evaluation findings looking to the future. The PHS evaluation also found that the shielding guidance was neither necessary nor sufficient to change behaviour in all instances. The conclusion was that a repeat of shielding in its initial form was not recommended, and that any future approaches would need to give greater consideration to personal choice, the multifaceted nature of risk, and hospital onset infections. The evaluation thereby helped the Scottish Government to shape and evidence their support for people on the highest risk list. PHS was advised that Scottish Government colleagues used findings from the evaluation to input into Cabinet papers around the removal of legislative COVID-19 restrictions. Do you agree with the recommendation that future programmes should consider more fully the risk of hospital onset infections?
Yes, I think this was rather a blunt instrument. Hadn't really been introduced, although notions of cocooning had been tried in other countries where you're trying to either ring vaccinate vulnerable individuals in their household, or looking at ways of trying to minimise spread. So this had not been done before. And I think one of the key issues is that it was done, it has been reviewed, and there are lessons identified in that need to be taken account of in any future pandemics.
Particularly focusing on the risk of hospital onset infections, are you aware of any resultant review of safety measures in place in healthcare settings, or consideration of changes which should be made to reduce the risk of nosocomial infections for the clinically vulnerable when accessing healthcare?
I'm not personally aware of this, but again, that is something I could look into and provide information to the inquiry.
More widely, can you help with how the findings of the evaluation were used by the Scottish Government to mitigate the impact of COVID-19 on the lives of the clinically vulnerable?
We do not usually have access to cabinet papers. Therefore, I've not seen the content of the cabinet paper referred to. Therefore, it would be difficult for me to comment on how the findings were used.
I'd like to move now to long COVID, please. Could we have on screen, please, paragraph 2.4.9 of the November statement? It's page 19. And you say here, NSS has set up a long COVID programme and a governance structure to facilitate the work of a national strategic network on long COVID. The network supports NHS boards and health and social care partnerships to deliver services for people experiencing long COVID. Reporting to PHS Chief Officer Munira Ahmad chairs the Strategic Oversight Board for the network, and reporting to the Cabinet Secretary for Health and Social Care via the Scottish Government Directorate for Healthcare Quality and Improvement. The SOB leads and directs the work of the network on behalf of Scottish Government. As well as chairing the SOB, PHS provides public health expertise to the steering group that oversees the activity of the network's work streams. The National Strategic Network on Long COVID was only commissioned in March 2022, as the inquiry understands it. Is that right?
I don't understand.
The inquiry has received evidence that that is
Yes,
the date
sorry.
on which it was commissioned. If you have other evidence to suggest it wasn't, please do tell Her Ladyship about it.
No, that's correct. I was confusing this. Sorry.
The need for a clinical guideline for long COVID has been recognised in Scotland since September 2020, and a clinical guideline was in place by December 2020. Can you help with why the NSN on long COVID was not commissioned sooner?
I think one of the challenges in this area, and while I think post-viral syndrome, of which COVID is one, has been recognised for many years following infections like flu, Epstein-Barr virus, and a variety of other viral infections. And I think what it's done is highlighted the frequency of which post-viral syndrome occurs, and to some extent the lack of support and infrastructure that exists. Part of the problem, I think, with long COVID is that there is no clear definition of long COVID. There are no clear biomarkers. There are no clear understanding of the pathology or how it's caused, which makes coming up with clinical guidance on how to manage it challenging. And the guidance you were referring to was actually a joint guidance by NICE and by SIGN, which is the Scottish Intercollegiate Network, which comes together. I can't comment on how, the gap between that report being produced and the network being established. I do know that £10 million was made available to boards and other organisations to apply to this board. There have been challenges because this was a 3-year project, and obviously employing people on a fixed-term contract, recruitment is challenging, and I know that that has been extended for another year to try and take account of that. But as to why no action was taken at the end of 2020 until 2022, I'm afraid I can't comment.
The statement refers in the paragraph above to a commitment made in September 2021 to establishing an expert group. to identify the capacity needs of NHS boards and staff in delivering safe and effective and person-centred support for people living with long COVID. Why was such a group considered necessary?
I think it goes back to the point I was just making, that this was something I think was somewhat of a surprise, but on reflection, given that flu is also recognised to be associated with post-viral syndrome, then it is probably something that should have been anticipated. The challenge here is understanding the actual physiological or biological mechanisms, so knowing what would make a difference, what could be done to try and minimise it. What we do know is that that vaccination has a positive impact on the development of long COVID. Something like only 8 to 12% of people who were vaccinated who were hospitalised actually ended up with long COVID. And this compares with 50 to 80% of people that were unvaccinated and hospitalised with COVID. So vaccination is a positive intervention that can be offered. With respect to what other treatments could be offered, it's mainly psychological support is seen as a key issue, because fatigue, this sort of brain fog, which is a common description of how people feel when they get for long COVID or even COVID. So psychological support was a feature, and some form of physiotherapy to try and rehabilitate people. So I think the absence of an understanding of what caused it presented challenges in coming up with or developing services to be able to respond to people who suffered from this.
This refers to the point of the expert group being to assess or identify capacity needs. Is that the type of capacity you're referring to, understanding what service to provide, as opposed to how to use resources to provide it?
My understanding is that this was about the services to provide rather than the capacity to provide those services. That would be a separate issue, a separate argument, having established what could offer support and benefit.
There is a reference here to PHS and NSS working together to deliver on this commitment. Has the expert group been set up?
I'm afraid I'm going to have to come back to you on that. I can't recall,
Okay.
but I will come back and provide that information.
Turning finally, please, to the specific lessons learned issues raised in the November 2023 statement. Could we have on screen, please, paragraph 13.4.2? And this is under the heading of essential services. It is important that in planning for healthcare system resilience, that decision makers have an explicit and shared understanding of what constitutes an essential service, that this includes ongoing surveillance of inequalities in wider health outcomes and determinants of outcomes, including accessibility and quality of healthcare provision. Can you help, please, with what about the healthcare response to COVID-19 in Scotland prompts PHS to stress the importance of this?
This review or the lessons learned relates to the National Incident Management Arrangements, which was convened under the auspices of the health protection guidance around the management of incidents. So this is looking at, this report was looking at how that functioned, what could have been done better, and by inference, what the obstacles were to actually making this happen. My feeling is that this is implying that there were underlying resilience issues. We tend to operate healthcare services at 85 to 90% capacity, which actually leaves little room for expansion to deal with critical incidents. And that's good if you're actually running a system where you're trying to maximise your efficiency and effectiveness. What it doesn't help with is where you're suddenly having to respond to an incident. And I illustrated in the information around the SIGSAG, the intensive care report, that required a rapid expansion of intensive care unit facilities. But the one thing that hampered the actual provision was actually having the staff necessary to be able to make it function. So it's one thing to have a bed, but if you don't have the staff able to operate it and to look after the patient, then that's a problem. So that's one inference. The second one really is highlighting the need for the prompt reporting of data. SMR01, which is one of the main sources of data that we tend to use, can take several weeks to come through once it's been recorded and checked. So looking at how we can improve the speed with which SMR01, which describes patient's condition, where they were admitted to, the treatment they received, would be one way of trying to improve the resilience and improve that understanding. And finally, again, this ongoing issue around data requirements, having things like ethnicity better collected, better completed, and other issues around linked to deprivation would have enabled us to identify problems should they have occurred at an early point in time.
The two other points that are made beneath on behalf of Public Health Scotland relate to data infrastructure. We've dealt in some detail with data issues and whole system working and the importance of that. Dr. Finn, are there any other lessons that PHS or you personally have taken from the pandemic which are relevant to the healthcare response, which you'd like to share with Her Ladyship?
In terms of the healthcare response, one of the issues that I was struck when I moved from England to Scotland is the difference in the way that the NHS is delivered operationally. In England, we had NHS England, which was a separate management structure to the trusts, and really took an overview and oversight of and reached very rapidly a consensus on what should be in place to deliver the response to an incident. Things like HCID, high consequence infectious diseases, that is managed by NHS England. There is no similar body in Scotland. You have to go to, I think it's 22 boards, 14 national board, 8 national boards and 14 local boards to reach a consensus and agreement before you can get something fully implemented. And while this can be really helpful when you're allowing autonomy to deal with issues locally, trying to present a national picture which prevents inequalities happening inadvertently is really, really important, both in terms of delivering consistent care and responding to providing a level of care consistent with the need across Scotland. So one of the issues around healthcare would be to look at how we better coordinate NHS response in that situation.
My lady, those are all the questions I have.
Thank you, Ms. Price. Ms. Mitchell, do you have any questions?
Questions that I was going to ask this witness, I don't think he will be able to answer because of when he arrived at Public Health Scotland. I do, however, have one question in relation to a matter that arose this morning in terms of resilience and staffing, if I might be able to ask that.
I was alerted to that fact. Yes, you may, Ms.
I'm obliged, thank you. Dr. Finn, we heard earlier this morning, Professor Finn, we heard earlier this morning when you were asked about Public Health Scotland taking over from its predecessor, whether or not there were any challenges on the impact of the ability of Public Health Scotland to contribute to the healthcare response to the pandemic. And your response to that was one of the things that the creation of Public Health Scotland did was actually create greater resilience in the system. So as an organisation with a much larger staffing numbers, we were able to draw on staff from different areas to bolster up to support the efforts. I would say that actually the creation of Public Health Scotland enabled greater resilience and in fact helped the response. Now, you gave evidence also in January of this year to the inquiry at Module 2A, yes? Yes?
Yes, sorry.
Yes.
Sorry.
And in that, you were asked by counsel to the inquiry at the time about the creation of Public Health Scotland and the issues that that caused. And counsel to the inquiry, Mr Dawson, said, Professor Finn, we were asking you about this administrative change and in particular in light of the evidence that Dr McMenamin's already given about the earlier period before April and the extent to which the pressures had driven Health Protection Scotland service to near breaking point have on the effectiveness of the response. And your answer was, yes, I think people maintained a very professional approach to this separation. They tried not to let it get in the way of any sort of barriers to useful working. However, what effectively happened was that Health Protection Scotland lost a third of its workforce when we became Public Health Scotland. And over the period of the pandemic, we found ourselves going after the same group of staff. So we were advertising to fill posts, and indeed there was movement from ARHAI, as we describe ARHAI, to Public Health Scotland, and from Public Health Scotland to ARHAI, which I don't think was helpful. Now, I'm wondering if you can help us with this. If Health Protection Scotland lost a third of its workforce when it became Public Health Scotland, and over the course of the pandemic found itself going after the same group of staff as ARHAI, how did this enable greater resilience?
The greater resilience I was referring to was that within Public Health Scotland, we had a number of healthcare scientists that were involved in looking at things like some of the aspects of health improvement. And you'll see from some of the evidence that we presented that not only were we trying to simply respond to the incident as it was happening, we were trying to undertake work around the evaluation of how things like shielding, how ethnic differences may have impacted on the health of the people in Scotland. So the greater resilience is that this gave us greater capacity to consider some of those wider issues. I also said earlier today that although we lost a third of our staff to ARHAI, this was in effect an administrative change, and one of the things that we did very well was work with colleagues with whom a long-standing relations had been built up to try and mitigate some of those challenges facing us at that time. We also did receive additional funding, and that was to recruit additional staff, scientific staff. It wasn't without its challenges, but that greater capacity within Public Health Scotland, both in terms of servicing meetings, carrying out health improvement, carrying out some of the surveys that we needed to support that work, was actually extremely valuable. And had we not had Health Scotland as part of our organisation, I think would have been much more challenging to do.
Lady, I would like follow-up questions, but understand we're in a tight time schedule, so I
We
shall
are
leave it
today.
there.
I'm really sorry.
No, I'm obliged, my lady.
Thank you very much indeed. I think that completes the questions for you, Dr. Finn. Thank you very much indeed for your help for the second time. I don't think we'll be having to call on you again, but thank you anyway for the help you've given to date.
My lady, may I call, please, Professor Dame Jenny Harries?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth and nothing but the truth.
Jenny, I hope we haven't kept you waiting for too long. I understand that sadly you have a funeral you wish to attend tomorrow. I guarantee we'll finish your evidence this afternoon.
Thank you.
Thank you. Professor, your full name, please.
Jennifer Margaret Harries.
Professor, I know mean no disrespect if I don't call you Professor Dame Jenny Harries every time I address you. You are a former Deputy Chief Medical Officer. You are now the Chief Executive of the UK Health Security Agency, who we've been naming ARHAI, just for convenience. Yes. And I think you have made two statements in Module 3. First one ending 410865, dated the 31st of January this year, and a second statement on the 27th of June 2024, 489907. Cool. I'm going to try not to flip too much between them both, but forgive me if occasionally we have to. By way of background, is this correct? You are a doctor with specialist training in public health medicine and have a number of other qualifications in public health. Yes. I think you, in fact, undertook your clinical doctor with specialist training in Wales.
I did.
And prior to your roles with Public Health England, as it then was, you worked as a director for public health in Norfolk and Waveney, in Swindon and Monmouthshire. Indeed, you were chief officer of 2 former local authorities. And in your national work, you've contributed to various significant health protection incidents, including the Novichok poisonings, the first cases of monkeypox in 2018, Zika virus, and supported a number of other global crises in your role.
That's correct.
You were appointed, I think, the Deputy Chief Medical Officer for England between July 2019 and the 1st of April 2021. And in April 2021, were appointed the CEO of ARHAI, although I think we've heard that ARHAI didn't become operational until the beginning of October.
That's correct.
All right. And is this right, that throughout your the relevant period that we're dealing with, you did not work on the front line during the pandemic, but were clearly heavily involved in your role as DCMO and then CEO?
That's correct.
All right. Can I start with the topic of shielding, please? And you primarily deal with this, Professor, in your statement ending 410865, the January 2024 statement. And if it helps you, we have heard from a number of witnesses, including Professor Whitty, the Clinically Vulnerable Families Core Participant Group, Professor Snook. So we're familiar with the creation of the shielding programme and indeed the 2 lists, the clinically extremely vulnerable and the clinically vulnerable. But can I just take a step back and ask you, please, what was the aim of the shielding programme when it was first established?
So the aim when the shielding programme was established was a very simple one, which was to support those people who could predictably be at highest risk of a new pathogen to keep as safe as possible. Its primary aim was to prevent mortality.
Yeah. It may be some people are confused and think it was to prevent transmission, prevent nosocomial transmission, but it was essentially, if I understand your evidence, protective of those vulnerable groups.
It was voluntary and protective in the way the programme was organised. I think the confusion, if you'd like me just to explain, potentially was right at the start of the pandemic when epidemiology was being considered and various options modelled, different portions of the population, if you like, were considered and how that impacted or potentially impacted on the transmission of the virus. And I think as we went through, we may see this later, there may have been some confusion about some early thinking about control of the virus as opposed to the actual programme, which, as I say, was protective and entirely voluntary.
It was essentially about 17 million people who were deemed to be clinically vulnerable, is that right? And although the numbers for clinically extremely vulnerable, it was initially thought to be about 1.2 million people. And we know that once COVID analysis had been undertaken, those on the shielding patient list rose to about 3.8 million or thereabouts.
That's right.
So a significant proportion of the UK's population were either CV or CEV.
Yes.
All right. Now, the structure of the programme, if I may say, was not the most straightforward, but you have set out in your statement, and could we have up on screen, please, 410865 at page 11, a helpful table setting out who was generally responsible for which aspects of the programme. We can see that the Ministry of Housing, Communities and Local Government, as it was then called, had overall responsibility. OCMO, of which you were then a part at the beginning, led on the development of the criteria. And if we go over the page, we can see DHSC's responsibilities set out. NHS Digital, as it then was, were drawing on the data. And NHS England and Improvement developed the first letters. And if we just scroll down, we come to PHE and UXA. PHE contributed to early clinical discussions led by the CMO. And then in due course, you became, is that the Senior Responsible Officer, the SRO?
Yes, I think it was actually Senior Reporting Officer,
Thank you.
but for a different programme. And there was obviously a gap between when I left my DCMO post at the end of March 21 and when the EPP, the Enhanced Protection Programme, was established in 22.
I'm going to come on to the Enhanced Protection Programme in a moment, but that just sets out the number of bodies involved. And can I just ask you to stand back? Do you think it was helpful to have that many bodies involved in such a significant programme as the shielding programme became?
So I think it's difficult, but it was inevitable, and I'm sure we'll go on to understand why. But I would just like to point out that there was an overarching government department, and it was MHCLG, it became DLUC. So it was very clear where that overall responsibility was. The part that I played, and I'm sure we will come into this, was around the clinical elements of understanding who might be at greatest risk at the start of the pandemic.
Yeah. Now, I think the shielding policy you say in your statement at paragraph 38 was announced on the 16th of March 2020, so the week before we went into lockdown.
Yes.
And why was the programme brought into being before there was the decision taken to go into lockdown?
So I think if we look back to Module 2, there was quite a lot of discussion about the need to move very rapidly at that point. So the original SAGE modelling of how the pandemic was likely to pan out and the identified peak of a 12-week period when we were expecting to advise those who were most at risk to keep out of circulation. Actually, much of that got pulled forward, and so the advice broadly to the population, as well as the clinically vulnerable and clinically extremely vulnerable, became slightly condensed. That was inevitable because of the detection of more transmission in the country than was envisaged at the start.
So if I understand you, there was always a plan to try and protect the vulnerable groups,
Absolutely.
but as a quirk of, I'm afraid, the high number of deaths and what we were seeing in Europe, the lockdown was brought forward, which has tended to perhaps merge the two in some people's minds.
Yes.
I understand. All right. You do say, though, in your statement that it was, I'm looking at your paragraph 44, Professor, it was recognised at the start that whilst the majority of individuals could be identified relatively quickly, for others there would be a time lag. And can you help? Did you know at the beginning what that time lag would be?
No, we'll probably go into the detail of this, but this had never been attempted in any country before. The only reason really we can attempt it, I think, in this country is because of our national health system and some of our connections across that. And so we knew what we wanted to do was identify those people who we thought clinically plausibly were most at risk and reach them as quickly as possible. And some of those we knew we could reach very quickly through digital means. Others we knew would not be able to, but we weren't able to predict exactly how long that would take at the start.
Can you help us to...
Sorry to interrupt, talking about
sure.
quickly, if you could slow down a bit, or
sorry.
I think I might find face screams from the sonographer.
Apologies.
Thank you.
those that you could identify quickly, can you help with what groups or types of vulnerability they had? How were you able to pick out one group more quickly than the others?
So the programme overall was if we use the word digital cohorting, so what we were trying to do was electronically identify people. So effectively, those where records were good and coding was consistent were the individuals we were most likely to find systematically. So, for example, somebody who had been being treated for cancer, I think we've spoken about the groups before, over a long time period, you would be able to identify. But if we then took somebody who perhaps had only just been identified, they would not necessarily be flagged in their GP record. So it was 7 different databases connected eventually, but we would not necessarily be able to pick them up. And particularly important was the fact that, for example, some treatments, immunosuppressive treatments, were being prescribed in secondary care, and those would not necessarily be on a GP list.
A number of points arise from that, if I may. We also know that there was, in due course, the ability for general practitioners to identify their own patients that they felt should be shielding. But help us, please. Number of different databases clearly caused a degree of difficulty in merging them. What happens in the event of a future pandemic? We're trying to speed up if one needs to identify a CEV cohort or a CV cohort.
So I think this is a really important opportunity for the UK particularly, because of our national data systems, to be able to alert individuals and provide advice to them very early in the event of a pandemic or serious pathogen. One of the problems here is coding, so if we don't have the information to start with, I'm sure we will come on to talk about inequalities. So we need to be clear, for example, around ethnicity, which is not systematically recorded. We also need to be very clear about medicines and treatments that people are having right across the system. So all of these databases need to be able to speak to each other and be as available as possible. One of the things we found was initially, and this has already moved on, that we would have to update the database, and that was quite a task. So it would update weekly. It wasn't instantly available. So, and different systems would update at different times.
Can you help us, Professor? Who is responsible for sorting out the coding difficulties? Is that NHS England, DHSE?
Well, complex topic, please stop me if I say too much, but initially all clinical professionals have responsibility for ensuring appropriate coding on the front line. Sometimes that's difficult because people are very busy, but it is really important because for exactly the reasons we're seeing here, if we want to be able to support individuals, we need to know what the intervention they had was or what their illness is. So somebody has to put the coding in, it has to be accurate and it has to be consistent and updated. But then the actual collation of that and responsibility flows through a number of different systems. You will have seen on the responsibilities chart, NHS Digital at the time was the organisation who was, I might say, brilliant in the work that they did on this. And really stepped up to support collation of these data sets.
And who's responsible now for
So I think
collation?
that will be within NHSE.
Okay. And do you know, we will be hearing from NHSE witnesses tomorrow and indeed into next week, but do you know, Professor, yourself, how long it would take a frontline professional to enter in coding, age, ethnicity, diagnosis, treatment? I'm just trying to think about practically, what are we asking our frontline professionals to do here?
So it won't always be the individual at the front line. It will vary with different parts of the system, primary care or secondary care. If, for example, if somebody has a surgical intervention, they have an operation, that should be coded both by the surgeon, but actually there should be a check in the administrative system of the hospital. So it varies. And of course, basic information should be sitting on a patient's record, full stop, and should obviously be updated and checked regularly, but won't change significantly. I think the important point is these different parts, the entries are in different places and they're not automatically linked. The opportunity going forward, of course, is for electronic patient records and appropriate connectivity. But with that comes obviously sensitivities around responsibilities and sharing.
And do you know, is there any difficulty with getting data from patients that live in Wales, Scotland and Northern Ireland? Is it easier, harder?
So each country is responsible for its own data systems and they speak differently. I mean, Wales, for example, has very good, you may have seen in my report, SAIL data, where it can do a lot of very good connections between social care, local authority data and health data. But it does vary, and we were reliant, you will see with the shielding programme that whilst there was a clinical agreement, actually the implementation of that across the different systems necessarily lay with the different countries.
Can I ask you this? We often hear that the work is being done. It's a good idea. We're moving it forward. But if we were to hit a pandemic next Monday, heaven forbid, how confident are you that these data coding issues would actually be, if not resolved, better than they were when we were here in March 2020?
I'm confident they have improved. There was a lot of learning through the pandemic. So the data foundry in the NHS has improved significantly, I think. But nevertheless, we would hit many of the problems that we had before. And I think those are the opportunities for the future.
Does it require legislation?
Well, I think it's not simply legislation. Actually, we need patients to understand similar conversations as to do with research trials, to understand why it's beneficial to share data and to give assurance, I think, that data is carefully used.
Understood. Can I just go back to where we started a moment ago and the time lag between some people being identified as CEV? You weren't able to sort of pin down a time frame for reasons that you've explained, but what about the risk to those people who were at the end of the receiving of the letters? Was there any support or information provided to them at the beginning, even though the letter hadn't actually landed on their doormat?
So I think if I start with people at the end, those are by the time we got to that, Q-COVID is separate.
Yes, it is.
But for those people, if you like, at the end of the first phase, I mean, we could have waited and sent out all of those letters all at one time when we got them, but clearly that feels ethically inappropriate. You want to reach anybody who you would like to give advice to as quickly as possible. I think the reasons which I've outlined about data are important, and it is also really important that it wasn't just GPs, actually, it was secondary care professionals as well, were able to add individuals. So in that time frame, we were either directly through linkage with some of the representative societies or through NHS England, linking with clinicians, specialists, who would also then advise their patients. So there was activity going on during that time.
I understand that, but what I was trying to understand is if you know you have had an organ transplant, for example, and therefore are likely to be deemed CEV, but don't actually get the letter, what was done, if anything, to try and support those people whilst they were waiting for the formal notification? Was there anything put up on websites or any messaging gone out to reassure them pending that letter being received?
So DHSC had the overall responsibility for communication, for the policy side of it. I mean, obviously it's a clinical topic, and I personally and many of my colleagues would support that. But the linkage out to patients also went through the NHS. So you may hear when we discuss perhaps some of the clinical reviews, we were liaising all the time with specialist clinicians. I think importantly, we talk about the shielded cohort, but this is not, these are very, very different people with very different illnesses and diseases, and what we're trying to do was work with the specialists in those topics who could then link with their patients.
So a one-size-fits-all would not work.
It doesn't, and actually you can have, for example, a young person of working age with a specific immunocompromised condition. These are not, as I think are sometimes considered, all very elderly individuals, for example. They have very, very different diseases, backgrounds and contexts, and they changed as the pandemic went through.
I think having started the programme, in your statement you make reference to the future of the shielding programme at your paragraph 49 and possible growth of the group asked to shield, and you were asked to provide some advice to the Department of Health in that regard. And I'd like to ask you about the advice you gave, which I think is probably set out in part in an email, 151804, please. _ page 2. We are in late April of 2020, and there is quite a long email, which I won't go through, that starts on page 3, but there was a request of you and others, as I think the department and the ministers were thinking about considering changing shielding as they were thinking about reviewing social distancing. So that's the sort of context in which the email arises. And then you were asked to provide your comments on shielding. And if we look at page 2, can you see their sentence beginning, Cabinet Office? The Cabinet Office have asked us to flesh out some next stage options on shielding in more detail and asked to consider extending it, relaxing it in some way, further segmenting shielding cohort, and indeed applying shielding guidance to household rather than individuals. So a number of different options at all ends of the extreme, if I can put it like that. So that was up for discussion. And I think if we turn to page 1, we have set out there an email from you where you say, I feel quite uncomfortable with the elaboration in the document, which seems to miss some of the very high-level key points. And then you set them out. But are you able, Professor, just to help us, what was making you uncomfortable about the options that were being considered at the end of April 2020?
So I think what you see in this email exchange is a continuous push and pull, if you like. So I was very clear what my role was. It was to protect a group of individuals with heightened clinical risk, as we understood it at the time, in what was definitely a voluntary system, and to support them. I think, unfortunately, and I refer back to some of the comments I made at the start around the SAGE modelling, which was entirely appropriate, but perhaps what different parts of the system took from that was that every time there was a conversation about changing the social distancing rules, it was quite what I would call a tactical, technical conversation, and perhaps didn't recognise some of the points I've made earlier, that this is a very heterogeneous group, that often people would be feeling very frightened, that you couldn't just put a date on a chart and say this was how we were going to change it. So again, you can see in line 2 there, the ability for people in the group to choose not to wish to shield is still missing in several places, and this was a recurrent problem, which was this was voluntary. It was there to support people who wished to shield, but it often came across in some of the media or the commentary as people being required to do things.
We weren't going to look at a shielding letter through you, but I have to say it doesn't strike you as immediately obvious that this is a voluntary option for those that were required to shield. Can I just ask you about that messaging? If there were to be a shielding programme in future, would you recommend changes to the letter that, I know it wasn't your responsibility, but the letter that went out, highlighting the voluntary nature, if indeed it is voluntary in any future programme?
So I did input to the letters, and I would add that for colleagues who are drafting them, sometimes it could be more difficult than it might appear. So, for example, to ensure support for statutory sick pay, which is something which I very much supported, there had to be quite technical wording in places which wouldn't feel immediately personable to individuals who were perhaps frightened with an illness in a pandemic. But I do think, I wouldn't say the letter was necessarily the thing that was the problem. I perhaps draw two examples. One is every time there was an announcement going out at ministerial level, although, as I think Professor Whitty said, we were told when we were on the number 10 podium or not, I would actually actively try to get on the podium, and that was to ensure that when a message was going out, the voluntary nature of that was very much put forward. Second example might be, I probably got better at doing this myself as we got further into the pandemic, and if there was an announcement, I on a couple of occasions did what we would call off camera but on record media group conversations to explain to the media what we were doing and why. And on one of those, I distinctly remember saying, this is what I expect your headline to be. Please do not write it because there are frightened people out in the public. And so there was always a tension between getting the communications of this right.
Can I just ask you this? Do you know, or do you know if there's any work has been done to ascertain how many people that were deemed to be CEV volunteered to shield and those that decided not to?
So much of the information which you may come is quite confused in terms of feedback, because it does, as you say, not everybody who was asked, often the data includes people who were asked to shield and people who shielded themselves. And so it's very difficult to disentangle.
So in short, we don't know what...
So there were attempts, and actually ONS and I think DHSC did write out, but obviously the response rate from something like that will not necessarily uncover the true numbers.
May I ask you about one of the options that was being positive on page 2 of this email, which was applying shielding guidance to households rather than individuals. And her ladyship heard some evidence from Dr. Cathy Finnis, who spoke about the difficulty experience where one person was shielding but the rest of the house was going about their daily business. What thought was given to try and apply the shielding guidance to households rather than individuals?
So I think there was strong recognition of this issue. We know in the first wave, I think we had around 0.6 million individuals who lived on their own, and about 1.2 in the first sort of few months who were living with somebody else. Sometimes that, of course, was somebody else shielding, so they were shielding together, if that's not an oxymoron. But it was actually practically very difficult. SAGE, I think, did some modelling on this early on. It was one of the reasons that they didn't go to the cocooning route, because once you start moving out to who needed support, it became very, very difficult to identify a household and or a confined group. And it was recognised right from the start that these were supportive interventions. They were never going to be perfect interventions.
I think in due course there was an email that you were copied on. Can we have a look, please, at 152001? We're now in May of 2020. And there was, I think, reference to bubbling and potentially getting various households together. And I think you had some concerns about that. And it follows on from your last answer, really. But what was your concern about changing the rules for the clinically extremely vulnerable to potentially allow them to bubble with either their own house, well, obviously with their own household, but with another household?
Yeah, although I would just flag allow with exactly the same point. People were allowed to do anything. This was the issue about what we were advising. And this is part of the problem with the communication. I think in this email what you can see it's a risk balancing proposal already, because there isn't a perfect answer to this. My concern was that whilst bubbles were being promoted, this is the push-pull very strongly, and there were lots of positive reasons for all sorts of people, single parents, elderly, people who were suffering with mental health conditions and needed support. There were also risks. And I think this email came before an appropriate communication. And one of the problems at this stage was that bubbling was being created or thought about, but with no limit. So, for example, as it was drafted, it would say you can bubble with one household. It didn't say you can't then swap your bubble. And so this is broadly trying to say this is a great thing, and we recognise, being tucked away brings significant morbidity in itself, but please be very careful about how this is articulated and thought through. So get the benefit, but balance it with the risk as well.
If we move on slightly from May 2020, I think shielding was paused, certainly in England, in August of 2020, and I think you were involved in some work in the run-up to that.
Yep.
And in particular, some work that you were doing in relation to occupational risk.
Yes.
And I'd like to ask you, please, about a paper and a roundtable you were involved in at INQ 421846, please. Now, here we are in July, and I think it was August that shielding was paused, so not long before. You were involved in a clinically vulnerable group workplace and COVID-19 risk clinical principles informed by DCMO roundtables. Can you just tell us, Professor, what did you actually do in the run-up to the pausing?
So I think what obviously you can see here, it was running up to a time of people getting back into society, to opening up workplaces, and also considerations of school opening in a number of different areas. And there was quite rightly consideration about how best to protect people. It also came on the back of things like the report from PHE on the impacts of COVID-19 on ethnic minorities.
Yeah.
And so there was quite a lot of discussion about how this risk and risk management was articulated in the workplace. And so what this roundtable did, and you'll find that I'm often called in to do roundtables between quite difficult or disparate factions to try and get some sort of consensus and shared understanding. This one included representation from NHS, who obviously had applied a specific risk assessment model, from the Faculty of Occupational Medicine, from a Health and Safety Executive, and a number of others around to try and pull all of that thinking together as we went into a closing or pausing the shielding programme.
Now, I'd like to ask you about the risk to healthcare workers to prevent them from coming to harm in healthcare settings. And I think taking your point is this is applying to a broader group than necessarily healthcare workers, but included them. Can I just, obviously you set out there at the beginning the responsibility to protect all workers from harm by carrying out a workplace risk management and providing a COVID-secure workplace. And was it envisaged that there would be different types of risk assessments depending on the setting that was being spoken about?
So one of the reasons for doing this workshop was to, if you like, reinforce the hierarchies of control, which are relevant both to, I think you will have heard about them during infection prevention control, but they are also highly relevant to risk management of any sort in the workplace. And that sentence itself, it says, by carrying out workplace risk management, of which risk assessment is a part. And I think what had happened was the NHS, for one organisation, had gone straight into individual risk assessment of particular individuals. And the whole thing needed contextualising in managing workplaces safely.
That's something I wanted to ask you about. Can we highlight the paragraph F? Because I wasn't clear here, Professor, what you were trying to get at. You make the point clearly. It's important to be clear about terminology. Workplace risk assessment, risk management, clinical risk assessment, and culturally competent conversations mean different things and should be used consistently. There is currently a focus on individual risk assessment, e.g. in the NHS, and the purpose and scope of this should be re-evaluated. Is it more proportionate and appropriate to ask for COVID conversations in clinical workplaces? Can we break that down? I want to understand, what was your concern with there being individual risk assessments, given that people may have very different risks depending on mobility, ethnicity, the role they're performing? I wondered if that was perhaps going too far the other way.
So this wasn't just me. Obviously, these are comments coming from a consensus statement from a number of different representations around the room. And it might be easier to work backwards, because that very last point, appropriate to ask for conversations in clinical workplaces, was actually the key finding from the qualitative outcome from the PHE Health Inequalities report. And I spoke to Kevin Fenton myself quite a lot on this, because there was a difficulty here. I think if we take the NHS workplace, my own concern, and it was shared with others, was that, if you like, I'm going to call it a knee-jerk response, but it was felt there was an anxiety, quite rightly. We were looking at data. People rushed to an individual risk assessment without assessing the full workplace. And actually, the qualitative work that came through was that the biggest difference in the ethnic and some other group within the NHS was that they didn't feel able to have the conversation, or they weren't enabled to have a conversation. When the conversation happened, people were reassured about the, if you like, PPE or whatever else it was in place. But the conversation needed to start with all of the different measures in the workplace that have been put in place to make the workplace safe. And so what this was trying to do was say everybody needs a risk assessment. You start with the workplace first and try and remove the risk, and you work through the hierarchies of control. And then back to, I know some of the comments others have made, which is the actual PPE bit is the very last point on this. And we need to risk assess every individual because it's the, and actually one of the other comments here was not just the individual in the workplace, but those conversations enabled the environment of the individual to be assessed as well. So, for example, when we had lots of peaks in, I think it was in Swindon, for example, in one particular workplace, actually the risk turned out to be people travelling in the cars together to the work. And so it's exactly why these conversations and the broader thinking was really important for understanding workplace risk.
And you would say that would still apply even in the healthcare setting. There's need to be that broader context.
Yes, because I will probably misquote the numbers now, so I won't. But I mean, the risk for healthcare workers was higher in community, I think, than it was from in the workplace setting itself. High risk of infection. But I mean, these are just normal parts of living. This isn't a worker issue. It's just actually thinking through where the risk of infectious disease might happen and managing it in all settings.
And so what was the outcome, if I can put it like that, of this round table, which I think was about a week or so before shielding was paused? What was the upshot as far as healthcare workers were concerned and the risk to them?
Well, this wasn't purely for healthcare workers.
No.
This was, as I say, this was primarily to consider the clinically vulnerable groups in whatever setting they were in. So this wasn't just focused on healthcare. It gave this was a statement really, which looked at all those risks and said, how can we support return to work of clinically vulnerable groups, ensure that they are supported, and this was fed back as well to BASE, so all the department names have changed now, but that was the business
energy industry.
Thank you.
Something like that.
And obviously the NHS were present as well. So it informed the thinking then of the subsequent cross-government guidance, I think, that came out as shielding was paused.
Can I just ask you more generally about occupational health risk assessments? Were studies such as Siren helpful in informing occupational health risk assessments or not?
So I think we need to distinguish between the workplace risk management, the cohort of staff, and then individual risk assessments. The Siren study has been hugely instrumental. So it started off looking effectively to see how many healthcare workers had been infected, but it's been used consistently then to track through the effectiveness of vaccination, how to best set testing regimes, for example, to ensure both the staff and patients are maximally safe, what that time should be. And it's still going, and I think you may have seen that that study is also being used now to assess some of the specific IPC questions as well.
And is a study such as Siren, I think, available to be reused again in the event of a future pandemic to help look at whether there is a risk to a particular group of healthcare workers or there's a particular nosocomial outbreak?
So, yeah, the Siren study was set up actually as one of the rapid public health studies. So there are health protection research units across the country. UK Health Security Agency has what we call twin hatters working in and out of research as well. There is the NIH, our National Institute for Health Research, has a new framework actually for responding to pandemics, whether it be to do with this practical implementation or whether it be to do with things like developing new vaccines or treatments. So I think that has moved on a lot, and that particular study was given rapid funding and is continuing to be funded.
We were... I paused to look at occupational risk because clearly some healthcare workers would have been deemed either CV or CEV and therefore at particular risk if they couldn't work from home. And that's really why I was trying to sort of broaden the questions into the risk to healthcare workers. Can I just ask you this, though? Clearly there was the pause of the shielding in August of 2020. And then by the autumn of that year, the prospect of another lockdown loomed large as we neared Christmas. What advice, if any, did you give to ministers, DHSE, about the prospect of a new national lockdown? If it helps you, Professor, I'm at your paragraph 55.
Thank you. I seem to remember.
We can put it up on screen, actually. It's 410865_20.
So perhaps if I talk through while that's coming up, and I'll hopefully check that it's what I think I said. I think at the time we were in the summer period. We knew, or we were pretty confident there would be further waves. Obviously, we're now used to that, but at the time it was difficult to know when they might come. There was a higher chance of any wave impacting more badly during the winter when people tend to stay indoors and accumulate closely together. And apart from a few areas, it felt that was the right time to give a signal to encourage people to be out more. It was both a climatic, I mean, COVID hasn't settled into a particularly seasonal pattern, but the risks are different during the winter months. And there was a particular concern as well that for individuals, when they started, the initial period was advised to be a minimum of 12 weeks. And the concern was actually if we needed to advise people to shield again during the winter in those coming months, it would be very difficult for people, both mentally and physically, to be right out of the system for a whole year.
Does that feed into your first bullet point there shown on screen, is that on the 31st of October 2020, you advised DHSE we should not return people to fully restrictive shielding, i.e. never leaving the house given the known negative mental health impact, particularly given the extended periods of relative isolation we've reached through the pandemic to date.
Exactly, and it's not that the the mental health impact to some extent was recognised. These are balanced risks. There wasn't an easy answer one way or the other, but the longer it went on, then clearly many of those risks accumulate, and if people had a break from them, it was an opportunity for a reset moment. And obviously no period is entirely safe, no individual was entirely safe, but this was probably the safest time.
May I just deal with two short topics before perhaps we take our lunch break, but I'd like to ask you just very briefly about Q-COVID. Now, Professor Whitty, I think, told us that the big delay in Q-COVID was pulling the data from the multiple sources together. And is that feedback to the 7 databases that we were talking about a moment ago? If there was another pandemic today, how soon would UKHSA and indeed the others involved in Q-COVID, be able to roll out a similar tool if it was thought necessary?
Well, you may have seen from the records, we did try to retain a model for doing that more quickly. Obviously, there are competing demands across the system, and that was not funded on an ongoing basis, and those decisions are made. I think what we did retain was a playbook as to how we would do this again, and for the reasons which I've said around the Foundry and other data systems, some of that would be easier and some of it would be quicker. It would nevertheless still require some time to step it back up again. I do think it's an opportunity. It could, to be able to digitally cohort people. It sounds a bit technical, as though we're counting numbers, not individuals. But if you're going to reach them very quickly, if we suddenly found, for example, there was a problem with something or an intervention, I think there are much wider opportunities than just responding to a pandemic. So this should be an area of urgent progress.
When you say it would take some time to be able to step it back up again, days, weeks, months, what are we talking?
Probably months.
Is there anything that can practically be done now to make that shorter period of time?
So the issues about data, which are recurrent, I mean, we're all saying them for a number of different reasons. So the issues around data, about being clear who owns data, about working proactively with the public to understand why that sharing is important and to give the reassurance about its safeguarding, to always encourage the continuity of the content of it. I mean, ethnicity, I started in public health work 30 years ago. Ethnicity was not being recorded properly. And that has two sides to it, because it may be that people are frightened to have that ethnicity recorded for different reasons. And so we're looking at it in a very technical point here, but it's very sensitive. And who puts the information in and how it's recorded is really important.
Aside from the data issue, and that's not to minimise it,
No, that is the major concern.
Are there any other barriers that might lead to delays with implementing a tool like Q-COVID, which has vaccination implications? It was helpful for getting a number of people on the vaccination list. So even if you don't shield them, it increased their chances of getting a vaccine first.
It was a completely novel approach. It won a number of prizes. It scored very highly on quality. It was externally assessed. So I think this was a really important way forward. I think it needs more familiarity across the system so people understand the benefits. But I think it could be, for example, it's a similar approach running almost parallel to some of the clinical trials work as well. They are all required around data and being able to reach people and for people to give information, their agreement in advance of something happening.
It's probably my fault, but aside from the data, are there any other barriers that we need to remove?
So I think being really clear who is responsible, you will see from the EPP, the Enhanced Protection Programme work plan, if you like, that in some ways I came back into that because as I'd stepped away and with a gap, there was a degree of confusion about all the different parts were running, but the oversight was not clear. So I think being absolutely clear who owns this going forward and who runs with it is really important. And I think that depends on the number of uses that can be applied and where that should sit.
My lady, would that be a convenient moment for lunch?
Certainly. You've got a better idea of, we've got a lot to get in this afternoon. Are you happy that I take the usual hour?
Yes, I am. Thank you.
Very well. You know that we take breaks certainly for lunch. 1:45, please.
All rise.